Ladies and gentlemen, thank you very much for inviting me to give this presentation on the highlights of coronary heart disease. Well, in the original program, as you can see here, we had these times, but then luckily due to the visit of the Pope, the times have been changed, so all of us had to sacrifice 8 minutes from our talk. So it's a real challenge. I have 15 minutes or even less than 15 minutes for this talk. So what I did here was which were the major studies presented at the major big congresses last year, and which studies really changed my daily practice. So which were the big congresses after the ESC last year? You know, we had the TCT, AHA, ACC, EuroPCR, and of course this year here. So let's start with the TCT, which was shortly after the last year's ESC Congress. It was in San Francisco, and I picked only one study per big meeting, which really changed a little bit my life and the life of our patients. So I picked up the LEADERS-3 trial, which was a very unique trial. It was comparing bare stent with identical structure, drug-eluting, or better, so to speak, a drug-coated stent, because no polymer was here. The hypothesis was that for patients with high bleeding risk, so this is a high bleeding risk study, many patients were on parallel anticoagulation. Using 1 month of dual antiplatelet therapy, the question is, can it be as safe and even more effective than the bare stent? And as you can see here, these were really sick people, elderly people over 75 years. Oral anticoagulation was planned, and even many patients had anemia. So this is really a population which usually is excluded from other trials. So here's the results of the primary efficacy, and this is something you would expect, that the clinical effect is better than this bare stent compared to the drug-eluting or drug-coated stent. But, and here comes the but, and this was really surprising, even the safety is higher. So you have more efficacy, more safety with only 4 weeks of dual antiplatelet therapy. So how did LEADERS-3 change my daily practice? Yes, it changed, because we have now a lot of evidence that only 4 weeks of dual antiplatelet therapy for patients on long-term anticoagulation after a drug-eluting stent is possible. So next was AHA in Orlando. And Denise already talked about the SPRINT trial, which was also presented there. But I picked something else. I picked the DEPT trial. Well, you might say the DEPT trial, that was already presented and published before. But what was new at the AHA was the DEPT score derived from the DEPT trial. As you can see here, the DEPT score is rather easy to be calculated with all these parameters here. I will not read them for the sake of time. But why do we do this? The DEPT score below 2 means you actually have no influence on myocardial infarction and stent thrombosis, but you pay a price for increased bleeding. So patients with a low DEPT score should not get this. And patients with a DEPT score of larger or equal to, you see there is a really highly significant reduction of myocardial and stent thrombosis and no increased bleeding. So prolonged DEPT, and this is secondary prevention. This has nothing to do with a stent. This is secondary prevention after a heart attack or in severely sick patients. I think this is what I'm doing today, and this changed my practice. I calculate the DEPT score, and if the patient is below 2, then the risk to prevent ischemia, the number needed to treat to prevent ischemia, is much higher than to cause bleeding. So you don't use the DEPT score, you don't use DEPT for these people, but with a high DEPT score, as you can see here, the number needed to prevent ischemia is much lower than the number of harming, and these are the patients who might benefit from prolonged long-term dual antiplatelet treatment beyond 1 year. So the next Congress was the ACC in Chicago. I picked one study, the Goss 3 trial. It was a large randomized trial comparing a new PCSK9 inhibitor to ezetimibe. But this is not really the reason I show this to you. I thought phase A was even much more intriguing than the phase B, because phase A was they selected patients with a history of intolerance of statins, and this was randomized, double-blind, and crossover. So each patient had placebo, and each patient had atorvastatin with a history of statin intolerance. And the interesting thing, which is important for practice, is that about 26% of the patients had muscle symptoms. They had muscle pains on placebo only and not on atorvastatin. I think this is very important data. So how did it change my daily practice? Yes, muscle pain or statin may be a placebo effect. So don't give up so early. And you just heard from the previous speaker how important statins are. So if somebody says, I still have muscle pain with statins, don't give up so easy. Just try another one. So let's get to the EuroPCR in Paris, which was in May this year. I picked up one study I thought which was important to my daily practice regarding the totally bioabsorbable stent or scaffold, but not the polylactate. In this time, it's the magnesium stent. And magnesium is also dissolving within some time. And the big question is, what are the clinical data? Well, we have in stent, or better to say in scaffold late loss, which is acceptable, like it is a drug-eluting stent or drug-eluting scaffold. But what I found was intriguing is there's absolutely no stent thrombosis, zero, even after 12 months. And I think this is a very promising alternative to the usually implanted absorb stent. So the magnesium-based absorbable scaffold might be an absorb alternative. Of course, we need longer follow-ups, like 2 or 3 years or even 5 years regarding this. Well, last but not least, we are here in Rome, so I picked up some highlights what I think might be important to my daily practice. I found this Pegasus update here, but this is not related to MI. This analysis is related to stroke. You know the results of the Pegasus trial. It's been fully published during the year. And this again is secondary prevention after a heart attack. Dual antiplatelet therapy for secondary prevention. And it is effective in the low dose 2 times 60 milligrams per day. But what I found interesting at this meeting, it does not only reduce ischemic events in the heart, it also reduces ischemic events in the brain. I mean, it's a 0.5% reduction of stroke. I think it's 1 out of 200 patients. So it supports the concept of secondary prevention data with dual antiplatelet therapy with aspirin and ticagrelor. Last but not least, and this are the last studies I'll show to you, I found 3 studies, one in Great Britain, one in the Netherlands, and one in Korea. They all were focusing on reducing unnecessary cardiac catheterization. So this is a real problem all over the world. Everybody wants to reduce unnecessary cardiac catheterization. Why? Because we have data that up to 60% of invasive angiographies do not reveal any hemodynamic significant stenosis. What is hemodynamic significant? It's a positive FFR test. So all these studies used FFR as a reference method, and I'll show you, for the sake of time, only one sentence for each of these studies. The CE Mark II showed that magnetic resonance imaging can avoid 3/4 of unnecessary caths. SPECT, interestingly, is equivalent to magnetic resonance. The Pacific trial showed that coronary CTA, so CT of the heart, to detect FFR documented stenosis is the same like SPECT, so which is equivalent to CT of the heart in the range of 74–77%. And last but not least, the CONSERVE study showed that CCTA with a CT coronary angiography avoids 75% of unnecessary caths. So when I come home, I think I will probably use more coronary CTs to avoid unnecessary catheterizations if possible. So here's my last slide, and I made this a little bit provocative. This is my personal take-home message from the ESC meeting this year. I think the major message to me is that there can be considerable savings be done in the healthcare system without putting the patient at risk. This is important. Don't increase the risk and still save the money with less defibrillators, with less telemonitoring, or even no telemonitoring, with use of established, cheaper drug-eluting stents. You don't need this durable polymer or non-absorbable metallic frames. We don't know. Shorten the duration of DAP to 4 weeks in patients on long-term anticoagulation. And last but not least, the avoidance of unnecessary cardiac catheterizations is possible. Thank you.
Thank you, Sigmund.